there, my name is Alyssa. I'm going to be the nurse taking care of you today. I'm going to wash my hands. I'm going to provide privacy. I am going to confirm your name and date of birth with 2 patient identifiers. I'm going to let you know I got my clean equipment here. I've got my stethoscope. I'm going to be doing a respiratory assessment on you today. Pertinent questions would include if you've had a recent cough, any sort of shortness of breath, chest pain when breathing, history of any sort of recurrent respiratory infections, if they have any known exposure, anything of that nature. I would count the patient's respiratory rate and would find hopefully something between 12 to 20, kind of our normal range. I'm going to look at their overall thoracic cage, and I'm pretty much looking for symmetry. Chest fall and rise is equal symmetrically for this patient. Now, depending on how you like to assess your patient, you can do everything on the anterior aspect first, posterior aspect first, or you can do kind of back and forth. I personally like to start at the posterior part of the chest and then work my way to the front. It is going to be a little bit challenging to do that on my mannequin here. He doesn't have a lot of great muscle tone for me to be able to assess him, but we are practicing our social distancing, so I'm using a mannequin today. While I have my patient looking at him here, I want to look for his overall position, making sure that he's comfortable, he's not tripoding, it doesn't appear that he's having a significant hard time breathing. His facial expressions will tell me a lot too about his comfort level and his ability to breathe appropriately, as well as his level of consciousness. If he's kind of drowsy in and out, I'm going to be concerned about his oxygenation. I'll start in the anterior chest, again, just because it's a little bit more challenging for me to get to his backside, so I'll start on my anterior chest. First thing is always inspection, so I am looking at his chest overall again for kind of equal chest rise, chest fall. I'm going to palpate just his overall chest wall, both sides, make sure I don't feel any sort of lumps, any sort of lesions. He's got appropriate texture throughout. His coloring overall is good as well. Next, I'm going to assess for symmetrical chest expansion. So in the front, I'm going to put my hands kind of at the bottom of his ribs, right, and put my thumbs close to his xiphoid process and have him take a deep breath in and out. And I should see my hands move symmetrically in and out when he's taking a breath. Next thing that I'm going to do is I'm going to feel for any sort of tactile fremitus. So I'm going to make my way around his chest and have the patient say 99. All the way around. You would have increased tactile fremitus if you had any sort of area of consolidation within the lungs. So again, the patient would say 99 as I'm feeling my way around. Next thing I'm going to do is in between the intercostal spaces, I'm going to percuss. Our gentleman here is pretty hollow, so I'm not getting the best sounds out of him, but my expected finding would be resonance. Unless I was kind of hitting down here closer to the liver, you can actually hear my sound change where things become a little bit more dull, and I might be over, if I was on the patient's right side, I'd be thinking I was over their liver. Sometimes you can hear a little bit of dullness on their left side if you were like kind of close to their spleen. I percuss throughout the chest. Next thing I'm going to do is I am going to auscultate breath sounds. I'm going to do this in 10 spots in the front. I'm going to listen for a full inspiration and expiration for this patient every time I move my stethoscope, comparing side to side. Take a deep breath in, exhale, in, exhale. Very good. I would want to flip my patient over and do kind of a very similar thing on the back. I'll do my best here with what I've got. So I'm looking for his back. I'm looking at his back, inspecting his skin, noting any sort of masses, any sort of lesions, kind of feeling around as well. He should have good temperature and good texture throughout. I would want to also assess for symmetrical chest expansion, so kind of putting my hands, again, kind of almost at the base of his ribs, if you will. Take a little pinch of skin in the middle with my thumbs and have him take a deep breath in and a deep breath out, and my hands should move in and out symmetrically. I would also want to do tactile fremitus on the back as well. Have the patient say 99, comparing both sides symmetrically. 99, 99, 99, 99, 99, 99, 99. I'm going to percuss on his back as well. 3 spots up by the APCs of the lungs. Remember how high the lungs come up if you're thinking about C7, kind of that landmark on your back, that's about as high as your lungs come up. So 3 spots on the back, up by the APCs. And then again, making my way symmetrically, side to side, over the lung fields. With those 3 extras on the top, there's a total of 22 spots I need to percuss while I'm on the back. Again, my normal finding would be resonance over the lungs, and would maybe anticipate hearing some dullness if I was closer to the liver. I am going to listen to a total of 18 spots on the back, thinking up pretty high, using the diaphragm of my stethoscope, listening for a full inspiration and expiration while I'm doing this. Take a deep breath in and out, in and out, in and out, in and out. And again, I'm going to do that. It's a total of 9 spots, making my way underneath the axilla too, to get a really good listen to their lung sounds. While I am on the back is when I'm going to do my voice sounds. We have 3 voice sounds that we do. We do bronchophony, egophony, and whispered pectriloquy. For each of those, I'm going to be listening in all 18 of those spots, same for auscultation. For bronchophony, I would be having my patient say 99, 99, 99, 99, again in those same 18 spots that I did when I was just listening to their regular breath sounds. What I would expect to hear is kind of that 99 to be soft or almost inaudible. If it was very clear, I'd be worried about consolidation. Again, in those same spots, I'd have my patient say a long E sound, E, 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 E. My anticipation would be able to hear the E sound. If it had switched over to an A sound, again, I'd be worried about consolidation. Also, whispered pectriloquy, I would have the patient whisper 1, 2, 3. Every time I moved my stethoscope. That should be almost completely inaudible. If it was very clear, you're able to hear the 1, 2, 3. Again, we'd be worried about consolidation. I would be listening for any sort of adventitious sounds while I was listening to their breath sounds. If I had heard any sort of wheezing, I would be concerned about lower airway obstruction, such as that with asthma. If I heard more upper airway sounds, specifically with inspiration, I'd be concerned about stridor, upper airway things. If I heard any sort of crackles, I'd want to make note of kind of where I heard them. Are they occurring on one side or both sides? And that can be indication of things like fluid or infection such as pneumonia. Put my patient back down here. I would discuss my findings with him and document my assessment.